Hello, everyone. I'm Amelie McFadden, the Chief Executive Officer of HPV Global Action, and I'm pleased to serve as the moderator for today's program. I would like to thank you all for joining us for today's continuing medical education webinar presented by HPV Global Action and the Consortium for Infectious Disease Control. Today's presentation is entitled, Will Canada's HPV Prevention Plan be on track with 2030 elimination targets of the WHO? We are very fortunate to have two international experts, Dr. Mark Stebbin and Dr. Nancy Durand, to provide this very important presentation. I would also like to thank Merck Canada, whose support has enabled this webinar to be provided at no cost to participants. In today's webinar, Dr. Stebbin and Dr. Durand will address the learning objectives that you can see on the screen currently. Apologize, there's a delay in my going. The objectives are as follows: enumerate the reasons why Canada is at risk of not reaching the 2030 screening targets for the elimination of cervical cancer, present actions on what Canada can do now to reach the 2030 screening elimination targets, enumerate reasons why Canada is at risk of not reaching the 2030 vaccine targets for elimination of cervical cancer, compare Canadian provinces and territorial coverage rates and obstacles, and discuss potential actions on how to increase the Canadian vaccine coverage. Please note that this webinar is being recorded, and the recording as well as the PowerPoint slides will be made available following the webinar. They'll be archived on both the CIDC and HPV Global Action's website. You can see both addresses currently on the screen at the bottom of the slide. This recording, along with recordings from past webinars and a number of useful resources, can also be found on both websites. As well, you can join the Canadian HPV network by completing the contact form online on the CIDC website. For a few administrative notes, you can hear the audio via your computer speakers. All participants have joined the webinar in listen-only mode. If you would like to ask a question, you can do so at any time during the webinar by typing it in the question panel and clicking the send button. The questions will be saved and submitted during the webinar, and all or some, as most as we can, will be answered following the presentations. We'll have a brief question and answer period. So once again, the webinar is recorded, and the recording and slide set will both be available on both CIDC and HPV Global Action websites. Finally, we do hope that all participants will complete the webinar evaluation. You can see on this slide currently a link for the brief evaluation survey. If you have registered for today's webinar and logged in with your own email address, you'll be sent an email following the webinar with the survey link. Otherwise, you can take note of it right now. And I will start by introducing today's first speaker, Dr. Mark Stebbin. Dr. Stebbin is a family doctor at the GMF La Cité du Parc La Fontaine. He is a member of the executive and responsible for the education committee of the International Papillomavirus Society. He is the chair of the Canadian Network on HPV Prevention. He is the elected president of the Canadian branch of the International Union Against STIs. He is a member of the executive of the American Sexual Transmitted Association. He is the associate editor of the Journal of Lower Genital Tract Disease and the Journal of Obstetrics and Gynecology of Canada. And he is also the co-president of HPV Global Action. Welcome, Dr. Stebbin.
Thank you, Emily. It's an honor to be here and talk to you about this elimination drive for 2030 called by WHO for the elimination of cervical cancer. So I'll be talking on the screening side of the elimination of cervical cancer. These are my potential conflicts of interest in the last 3 years. So I have a lot, and most of them are within the HPV or STD subjects. So I want to make a disclosure at the beginning. So what I'm going to be presenting about cervical cancer elimination is based mostly on cisgender women, but we need to recognize that any person who has a uterus should be provided with the same screening efforts to eliminate cervical cancer. So recognizing that there's a plurality of gendered, I'm going to be using the term women for all gender, the diverse people at risk for cervical cancer. So cervical cancer rates have not decreased appreciably in the last several years in many countries, and it's the fact in Canada, but all the other HPV-related cancers are increasing. Also, we know that the incidence and proportion of adenocarcinoma of the cervix is rising, and that the current screening tests used the most in Canada are not designed for detection of the non-squamous cervical cancer. And the proportion of women diagnosed with invasive cervical cancer within 3 years of their last screening is increasing. So it's important we take time to look at what should be done to make elimination possible. So there are mainly two books I'm deriving my presentation from. So there's the IARC perspective on cervical cancer screening. There's a special report in the New England, but there's the book available free on IARC website. And there's also on WHO website, the guideline for screening and treatment of cervical precancer lesions, the second edition, and the two web annex that are very richly informed that certainly I benefited from the material. So when is it appropriate and how can we get it right? So the screening is an important action in terms of prevention. It may bring benefit, but also it can cause harm. And it's just because it can be done that we should do it. The screening also should be done within an organized screening program. And when we look across Canada, the definition of organized screening program differs from province to province and territories to province. And I think it's important that we rely on screening principles that are the gold standard when deciding on screening program are made. So this is another book that you can find on WHO website about screening program in general. So care is needed because sometimes it can be commercially driven. It is important to look at the barriers even before the program starts, and the potential barriers varies from the healthcare structure, payment models, availability of resources, and we know we have difficulty in Canada to have the sufficient number of resources, the physical and the financial resources necessary for a successful program. And we need to look at the appropriate information flow between the population, the patient, the healthcare worker, the labs, and the surveillance people. And be sure that the healthcare worker have appropriate skills and that logistical barriers are prevented. So these are the Wilson and Jugner principles. So they date from 1968, and they're still very important and very solid nowadays. So the condition has to be an important health problem. There's a treatment that is accepted for the recognized disease. We have the facilities to manage these cases. There should be a recognizable latent or early symptomatic stage, a suitable test or examination. The test should be acceptable to the population. The natural history is known, and there should be an agreed policy on whom to treat as a patient. And the cost of case finding should be economically balanced to the expenditure. And case finding is a continuing process and usually and never just once and for all the project. So this is the framework they're giving us to look at the good screening pathways. So the first part is identify the population eligible for screening. So there are different population, of course. The first big division we have is about the HIV status, we see frequently two different paradigms of screening for HIV positive and negative person. And also frequently we see different in the management depending on the age of the patient, so not to provoke reproductive issues when it's the case for younger women. And also it depends on the frequency of screening you want to do, and the start time will varies. Some high-income country will start at 25, other will start at 30. And LMIC, the low middle income countries, they look at only twice in a lifetime at age 35 and 45. And at what age should we stop? High income country, most are stopping at 65, but recently Australia upped the termination time for screening at 70. And we know this is a fast growing population where there's death occurring. Before it was mainly women who did not have screening, but now we see that women have been screened and still at risk, maybe a little bit older than it was the case before. And LMIC, most countries will stop at 45 or 50. And we need a good registry to identify those patients that are overscreened. We know it's a problem that plagues our healthcare system. So many people usually overscreen, but also with low potential for disease to develop. And it identifies also underscreened, so we make special action for them to access cervical cancer screening. So in the WHO guideline, we look, and the suggestion now is to go with HPV DNA detection. There's also HPV RNA in the recent book, detection and a screen and treat approach from the age of 30 with regular screening every 5 to 10 years. But this is more for developing countries where facilities for the lab for triage is very limited, and where the prevalence of the disease is very high. For high-income countries, the second option seems to be the best. It's detection of nucleic acid in a screen, triage, and treat approach that should start at the age of 30 with regular screening every 5 to 10 years. WHO also talks about starting at the age of 25 with screening every 3 to 5 years when you do nucleic acid screening. The second step is who to invite and the information we give the people about the screening. And we know that maybe the best natural history that was done about the efficacy of a screening where women are called in is from UK. In the 80s, they introduced a national call recall that was introduced. And you can see that following the call and recall letter, you see a significant drop in the incidence of cervical cancer and cervical cancer death. And you can also see the coverage increase, but still plateaus. So call and recall may be beneficial for up to 85% of the population, still that 15% that is not screened. So the invitation will come usually in an organized program. There's still a lot of opportunistic screening happening, and I think it's going to be continuing even if we have an organized system for call and recall. So self-sample also should be made possible. We know that data from research with randomized controlled trial or control sampling shows that women are pretty good at doing a significant specimen, and it also follows the recommendation of WHO to do task shifting, where we give the responsibility for the lowest but competent person to do that chore. So do we reach the good people? So maybe we need to be opportunistic for hard to reach population, vulnerable population, and organize for specific medical or social services on top of the regular program for the general population. The information needs to have the right sensitivity, the right information. So sometime a focus group has to be organized to see exactly what women want to know about their screening. They should be told about the potential benefits, the potential harms, the right channel for the communication, and the hard to reach population needs specific information and maybe specific channel for the information to circulate. So many people who are living on the streets or in jails or do not have access to the regular information channel of the general population. So I like to talk about the general population. Of course, this is that 85% reach that is quite feasible in high-income countries, but we have those people that are the medically vulnerable population. We talk about people living with HIV, a transplant, immune suppression, autoimmune disease. They've been treated for cancer or they have treatment for cancer in STI clinic, the partners of the HPV positive people, and let's not forget about the HPV unvaccinated. We know that girls that have not been given HPV vaccine has a lower attendance to pap smear in their country. Also, we have those people that are socially vulnerable. They are marginalized, people with mental health issues, street involved, many times don't necessarily have a Medicare card, migrants, refugees, and displaced people. Most of them come from countries where there's absolutely no screening, no vaccine available. The First Nations in our country, people with less access to care and education, people in jails, in institutions. So we have to have opportunistic available for those people that are not necessarily attending regular preventive care with their nurse or their family physician. So WHO calls for 2030 to screen 70% of eligible women at least twice in their lifetime. In Canada, we have a 90% screening rate objective, and to effectively treat 90% of those with a positive screening test or cervical lesion, including palliative care. So let's start with screening 70% of eligible women at least twice in their lifetime. So the testing paradigm is shifting. I think there's no more data needed to make a decision to shift to nucleic acid testing. This is the work that was done and presented in preventive medicine by a group of researchers in Montreal. And we see that there's limitation of cytologic screening. So 50 to 60% of women declared with cervical cancer had no previous screening or too long between screening. 20 to 25% of women had all their pap tests as normal, not finding precancer, so they can have treatment. 8 to 15% inadequate follow-up that can be from the doctor's side or it can be from the patient side that they don't go for their test and treatment. The treatment failure and the rapid evolution of cancer are two lower frequency. So it shows clearly that there are limits to cytology, and I like to say that cytology was very good in the 20th century, but is not the tool that should be used in the 21st century. And we know that while we are vaccinating girls, those girls are arriving at the age of cervical cancer screening, and we know that the positive predictive value of cytology is crashing, and it's foreseen that there will be more harm done to women than benefit as the infection and the cervical disease decreases in the population. So that is why we need to shift. And also that the shift of paradigm is seen in many other diseases. This is a slide I used in the HIV point of care testing symposium some years ago. And we know that the healthcare system is conservative, very regulated, We know that the doctor knows best. There's a paternalistic attitude sometimes, and the need to prevent all harms at all costs. But we know that self-collection of HPV screening changes completely the landscape for screening. It has been shown to be safe, effective, preferred, and save precious and rare healthcare resources. So WHO, again, will talk about primary screening with HPV DNA, and that either sample taken by healthcare provider or self-collected be offered to women without HIV and for women that have HIV. But we know that HPV testing is a little bit more sensitive, but it's also a little bit less specific. So we need to do some triage. So the triage can be done by the HPV nucleic acid test itself. So we can do partial genotyping. We know that 16 and 18 are the two most rapid high-risk HPV to create precancer and cancer. We can use cytology as triage. We know it's a little bit more specific than cytology. In developing country, there will be a visual inspection with acetic acid, but I don't think that this is for high-income country. And there are biomarkers that will make it possible to distinguish cells that are highly at risk of transformation toward cancer. So we need not testing, we need the triage of these women. And we see these are the screening in women. So we see those less than 30 years of age and those that are 30 and over. And we see that the evolution from a time where there's HPV detected and the detection of a lesion that is high-grade disease of the cervix or worse is mostly seen in those women that are HPV 16 and 18 positive. And you look at the black line, so this is HPV positive, but HPV 16 and 18 negative. So the younger women, and we see in older women, it's even more clear that HPV 16 and 18 do create within 10 years a greater development of high-grade lesion. And for those women that have high-risk HPV not being 16 or 18, it's even much less than it was with women that were 30 years of age. So a lot of countries are moving toward partial genotyping as the triage test that is also rapid to be given. So this is the data that has been done by a working group for WHO, and you see that there are some benefit when you see the green, the heavy green line, the pale green is less benefit, the yellow it's not as well established, and the red is it should not be an option. And you see what stands out also with the discounted lifetime costs for patient. And we see that HPV triage, HPV with 16 and 18 triage every 5 years is producing some of the best prevention of cervical cancer death. And you look at the price, also it's quite within the economic possibility in high income countries. After that, you need referral for screen positive and reporting of screen negative results. So we need to have an adequate and accessible referral system. So this is a need. You don't start a program if you don't identify correctly the people, but also if you don't have adequate and accessible referral system. A system for screening will have limited value if those that are identify a need for their investigation and treatment are not able to access these services. And it should be as seamless as possible. And I don't think at this moment that we can say in Canada that we've worked so much to be sure that women that are diagnosed are really going for colposcopy, and there's something wrong with colposcopy, we call them back for treatment. And there should be fail-safe checks in place to catch those who do. And now we're going to look at those women that test positive or have lesions. So we need to have 90% of those with a positive screening test or a cervical lesion, including palliative care when needed. And in Canada, we have 90% of all individuals. This is our objective, that have appropriate follow-up. And again, this is a problem. I don't think we have very good and solid callback system, especially if those, for whatever reason, cancel or are not reachable. So I think even 10% of women lost to follow-up is not pretty and should not happen. And the diagnosis and the intervention treatment follow-up. And for those women who require treatment, we should have appropriate and timely way. But we know also that there's huge time, waiting time for women who have abnormality to have colposcopy because of COVID. A lot of screening was not done, a lot of abnormal lesions were not done, and we have some kind of bottleneck effect in many colposcopy clinic. Ultimately, there's no point of offering a screening test if there's insufficient facilities to provide it. And those people that will require follow-up to repeat screening as part of a wider surveillance of the disease. So they should have, those who test positive with the screening should have staff diagnostic services, triage or rapid access. Counseling may be needed because there's a lot of anxious patients that are found, or couples where there's difficulty because now we're dealing with a sexually transmitted infection and not pre-cancer. And also, we have to be clear on being open to a diversified population. We want transgendered patients, those women that have been genitally mutilated in their country, patient from the sex trade. So we have to be open because for many women, having a pap smear and colposcopy is something that can be traumatic. So we have to adhere to the principles of a trauma-free intervention for all patients that come to our clinic. And soon to be released, we'll have a new booklet about counseling patients about HPV, about the test result, the prevention, and vaccination. So you'll be informed. That will be on CIDC website. So a lot of resistance from some doctors because they feel it's lengthier to explain. It's pre-cancer, you go to treatment, everybody accepts and doesn't create so much trouble behind adjustment to a potential pre-cancer diagnosis. We frequently hear also that HPV testing is more expensive. Well, it's more expensive, but the saving that is brought by the decrease in cancer is so important that it's saving money at the end for the healthcare system. So better value for not only the patient, but also for the healthcare system. And when you look at the HPV testing, the overall sensitivity would be at 95% with a specificity of 84 compared to the cytology that might approximate VIA. And we see that there are more women that are treated when you do HPV because it's a little bit less specific. But you look, the missed case, the false negative, is way down compared to the examination of the cervix or even triaging HPV tests that are positive with VIA, and all indicators like mortality, cervical cancer, and CIN2-3 recurrence is much lower than the other techniques. But of course, there's more bleeding, pain, more patient that will talk about pain and major infection. But overall, the missed case are way down with HPV testing. I'm not going to go through the algorithms, but in the green booklet from WHO, you have the main algorithms. So primary HPV DNA screening with the triage with VIA. So that is mostly for the developing country where more specific tests are not available. The follow-up that is recommended after a negative triage test, so a woman that has a positive HPV test but triage is negative, or after treatment because there was a lesion. So the evidence for follow-up after a positive HPV DNA primary screening and negative triage was based on modeling at 12 and 24 months or both. And it's clear that the screening at 12 months is suggested because it's not accompanied by more harm, and it finds the same amount of lesion in the follow-up of these women. But the big problem, where we have problem not only in developing countries but in Canada, is loss to triage. So there's something wrong. People don't come for the triage, and of course they cannot be treated. The loss to active surveillance after histological confirmation done at colposcopy or VIA in a low and middle income country was significant. In some places, it was up to 50%. And of course, the lengthier the time between the positive test and the triage test is the highest the risk of losing these patients. And loss to treatment, you see that systematic review of women with histological confirmation varies from loss of 58% to 100%. This is unacceptable. We don't have good data on this in Canada, but we see the importance of having these surveillance mechanisms to follow these patients. So in the Green Book, there are 3 different sections. So one is the regular screening intervals. Then there's the follow-up for women who have a primary HPV test, but a negative triage, and also the follow-up of women after treatment. So I encourage you to go see the document if you need access to these algorithms. And finally, the reporting of outcomes. So we need to identify if the overall program is meeting its objective, identify the elements that are functioning well as those that do not function well. We need a high level of uptake by different groups in the population, that patients have a positive experience, which is not the case everywhere. And those in whom problems are identified are referred and leading to health gain for the patient and for the system. Require linkage to other data sources, mainly cervical cancer screening registry linked to cancer and HPV vaccine registry, and that I don't see that it's available everywhere in Canada. And proper monitoring and evaluation should also take account of change in the technology as it emerges in the future. We need quality assurance program, and we need the screening registry, the call and recall effort log, and the strong lead needed between the individual and the multiple level of healthcare to ensure the continuity and completion of care. Finally, I think it's good to come back on the trauma-free values of cervical cancer screening program. We know that this is something that is main concern. Women who are traumatized because they have pain, because the personnel is not respectful of their intimity or their lifestyle is a good reason for women not to come back for the triage, the treatment, or for a second screening. It's an intrusive medical act. It's not, we should not trivialize how women feel when it's time for their screening, and we should have, and all individuals should have the right to equality and non-discrimination, reminding that many individuals have been traumatized in their life by abuse, molestation, mutilation, pain, being marginalized, and receiving healthcare that was not necessarily at the level they needed. So as again, this report was mainly based on studies of cisgendered women. So we consider the needs of all individuals independently of gender identity or its expression to be respectful. And of course, when we look at the elimination of cervical cancer efforts that we see in Sweden, we see that the vaccine part is very important and much more important to sterilize the infection from the population. So screening adds to the vaccination, but let's not think that we don't need vaccine because we have screening. It's better to prevent infection than follow infection. That is why the vaccine part will come and is so important. So we have the choice. In Sweden, they look at doing a catch-up vaccination to age 30 to reduce the R0, inducing elimination of vaccine, HPV types, followed by a one-time HPV screening, giving permanent evaluation of cervical cancer. And that's in the program of the Swedish cervical cancer program. So my conclusion, we have the tools, we have the WHO objectives, we need your commitments, and together we can eliminate cervical cancer. So thank you very much for your attention, and I will let my colleague Nancy to follow.
Thank you, Dr. Stebbin, for this very informative presentation. Our next speaker is Dr. Nancy Durand. Dr. Durand is an associate professor in the Department of Obstetrics and Gynecology at the University of Toronto in Canada. She received her medical degree from McGill University in Montreal, Canada, and completed her residency in obstetrics and gynecology at McGill University. She is on staff at Sunnybrook Health Sciences Centre in Toronto, Canada, in the Department of Obstetrics and Gynecology. Her clinical practice focuses on HPV and colposcopy. Welcome, Dr. Nancy Durand.
Thanks so much for the introduction, Emily and George. I'm just going to switch screens. Are you guys able to see the screen? If you could just tell me.
Yes.
Oh, great. Thank you so much. So my task for today's talk is in Canada's prevention plan, and are we on track to look at vaccination in Canada for HPV? These are my disclosures. So the question is really, are we on track to achieve Canada's 90% HPV vaccination targets by 2030? So to answer this question, we have to understand both Canada's current HPV vaccine coverage, and we also need to consider methods to increase our HPV vaccine access and improving vaccine uptake through better education and messaging to the general population. So let's first consider the approval and the recommendations in Canada for HPV vaccinations. And as I'm going to show you, there is a distinction between approval and recommendations that we need to understand as providers. In Canada, we currently have 9-valent vaccine and bivalent vaccine on the market. HPV quadrivalent vaccine originally was licensed in 2006, was withdrawn in the Canadian market in 2015 when the 9-valent vaccine became available. The indications and ages by Health Canada have definitely evolved over time and are shown here. These are the current indications. And notably, you'll see that adult male ages now match the ages for females. In addition to prevention of cervical cancer, vulvar and vaginal cancer, the 9-valent vaccine is also approved for prevention of anal precancers and cancers. And then the indication for prevention of HPV-related oral pharyngeal cancers was added in 2022. NACI recommends HPV vaccination in all individuals, male, female, or otherwise, from the ages of 9 to 26. And for the past several years, NACI has supported vaccination over the age of 26 with no upper age limit. So this gave us the freedom as prescribers to prescribe HPV vaccination to all of those, not just under the age of 26, from age 9 to 26, but also over the age of 26. And in fact, over 50 countries worldwide have now no upper age limit for HPV vaccination. It's important for us to remember also that NACI has always recommended vaccination of those with current or past history of HPV-related diseases. We sometimes forget that. We need to consider the importance of our society's recommendations and statements. And so, for example, the Society of Gyne-Oncologists of Canada published a position statement in June 2018 that went even further than the NACI statements, using even stronger language. And they actively recommend universal HPV vaccination in Canada, regardless of age. And then we have a joint statement from the Canadian Head and Neck Surgeons, SOGC, and Gyne-Oncology in January 2021, which was really a call to action to achieve elimination through vaccination, screening, and early detection and treatment of HPV cancers. So these position papers by our national societies are important because they carry weight within the medical community. They help to establish the standard of care. And this is how we can change our prescribing behaviors to increase vaccine coverage rates. So let's now look, what is the current state of provincially funded HPV vaccination programs in Canada? Well, in Canada, we're very lucky now that all 13 provinces and territories now vaccinate boys and girls in our school-based programs. They give 2 doses 6 months apart, and that's because the children being vaccinated in the school-based programs are starting their vaccines at age 14 and younger, which is when 2 doses is appropriate. All provinces and regions are 2 doses of 9-valent vaccine except Quebec, where the first dose is 9-valent vaccine and the second dose is bivalent vaccine. In general, across the country, the school-based programs vary between grades 4 and grade 7, depending on which province or territory you live in. So that's equivalent to age 9 to 12. We do have catch-up programs in some regions. In British Columbia, we have funded vaccine to the age of 18, basically till you leave high school. And if you start your first dose by the time you're 18, they fund the doses for completion of doses to the age of 25. In Ontario, we have funded HPV vaccine up until the time you leave high school, about grade 12. And right now, Ontario is also offering an additional catch-up to those in the first 3 years after they have left high school. But unfortunately, that program will end in August of this year unless it's extended. Quebec, we have a girls-only catch-up program to the age of 18. But we really look to 3 regions in Canada: Alberta, the Yukon, and the Northwest Territories have funded vaccine for all up to and including the age of 26. And this is really a standard that I think we should all aspire to. Special populations have additional funded doses for high-risk individuals, such as men having sex with men. And 6 of our regions have funded doses for those who are HIV positive. So unfortunately, the province in which I live, Ontario, the most highly populated province, is not one of this list. And that means, for example, in Ontario and 6 other regions, men who have sex with men who are HIV positive will get funded HPV vaccination. However, women and others with HIV who are not MSMs will not be covered. And that's, I think, a gap that we really need to fill. So although all children in Canada have funded doses, our uptake is not optimal across the country. For example, if you look at Ontario's numbers, in the 2018-19 school year, which is before COVID, uptake continued to be less than 60%. Other provinces like Newfoundland and PEI have much better uptake rates, but we really need to work harder in provinces such as Ontario and British Columbia. And as you can imagine, most of these programs were halted in early 2020 because of COVID, and our uptake rates dropped from, in Ontario, what wasn't a very good rate, less than 60%, down to less than 1% during the year 2020. And our catch-up programs post-COVID are starting, but are still very much behind the pre-COVID uptake rates. Ontario, for example, is only at 15% uptake for vaccination in schools last year. And the extended catch-ups is better, 23%, but still not where it needs to be. And so just like with cervical screening, in general, Canada is falling behind other countries such as Australia and the UK. High vaccine uptake rates in those countries has shown dramatic effects on reduction of HPV-related diseases, but our low vaccine uptake is not hitting our targets, and this decreases the effect of herd immunity and will surely slow our pathway to elimination. Therefore, we need to consider beyond just our school-based program and look at the value of vaccinating adults as well as adolescents. There is rationale to vaccinating adults. We do know there's a risk of new exposure. We try to vaccinate before those exposures occur as an adult. We know that HPV vaccines have been proven, as I'll show you, to have efficacy in adults. And we'll show you that also vaccination by HPV will reduce recurrences of those who have HPV-related diseases. So the evidence in adult women shows that in adult women over the age of 26, vaccination is effective with almost 90% reduction of persistent infection, abnormal PAPs, and external genital warts. And if you follow forward after the first 4 years of the adult woman study, up to 10 years, there are no breakthrough cases of vaccine-related disease. And as Mark mentioned, we're now seeing actual evidence of reductions of cervical cancer in this landmark paper from Sweden. Those who were vaccinated had dramatic reductions in cervical cancer, even if they were vaccinated up to the age of 30. The United Kingdom also shows dramatic reductions of CIN3, as well as reductions in cervical cancer when we compare the vaccinated cohorts to those prior to the vaccine programs. The data for adult males has also shown excellent reduction of disease. The younger male trials showed 90% reduction of external genital warts and dramatic reduction of anal precancerous cells. The adult male trial showed similar antibody levels to the younger males in whom efficacy had already been proven. What these trials are showing us that at 10 years and even beyond, that we have excellent durability of these vaccines at preventing disease. We often think it's too late to be vaccinated if you've already been exposed to HPV. And this thinking, I would say, is not just prevalent amongst patients, it's often prevalent amongst healthcare providers as well. So we want to look at the evidence for vaccinating this group of people. And we can see that dozens of studies have now found that HPV vaccination can reduce the rates of recurrence of abnormal PAPs, as well as external genital warts, as well as high-grade vulvar disease, even if we vaccinate after treatment has occurred. Similar findings have been seen in males with reduction of external genital warts, as well as reduction of high-grade anal lesions. So we can see that it's not too late to vaccinate based on your age, based on your gender, or based on previous HPV-related disease. And these findings have led many jurisdictions, such as Spain, most of Italy, Austria, and in Canada, in Manitoba and PEI, to now recommend and even fund HPV vaccination for those being seen in colposcopy or with a diagnosis of HPV-related diseases. So what then are our strategies for counseling for HPV vaccination that can help improve our uptake? When counseling adults, the following strategy can be very helpful and clear, and that's important. Why should you get vaccinated for HPV? Well, this is a vaccine to protect you against cancer. These cancers are preventable, and we don't want to lose you to this disease. Now, you'll notice when I gave those statements, I made no mention of it being sexually transmitted. So this type of counseling can be used in those who may not understand why they're suddenly showing up with HPV, such as someone who's in a so-called monogamous relationship. Two additional points we need to remember. Don't assume just because of a patient's age that they were necessarily vaccinated in this school-based program, because we know our uptake rates are not 100%. There will always be some adolescents who were missed vaccination during the school-based program, and we should still be counseling them. And when we speak to adult patients about the value of HPV vaccination, when they buy into its value, they are also those who either are parents now or may become parents in the future. And parents are more likely to consent their children for vaccination in our school-based program if they're properly informed about the benefits. So we really need to think about how do we open that HPV vaccination discussion. We need to actively look for those opportunities or windows where we can open our conversation. So there's some obvious ones listed here, and there will be others that you can think of as well. Anybody that we're having a contraceptive discussion, if we're talking about STI testing or external genital wart prevention. Travel vaccination discussions, interestingly, are a good opportunity to discuss HPV vaccination, because it's been shown that when we travel, your chance of having a new sexual encounter increases. Mental health visits is one you don't want to forget about, because often in younger people, and even those who are older, a mental health visit may often be due to a change in relationship status. And this is an excellent chance to discuss prevention through vaccination. Awareness campaigns, I think us with HPV really need to be thinking about opportunities for better awareness campaigns. Movember has been so successful for prevention of male cancers such as prostate cancer, and perhaps we need to look at even better awareness campaigns than we've had in the past. We really need to keep our messaging simple. There's really three things that patient wants to know. Does it work, number one? Is it safe, number two? And we can't forget, number three, we often do forget. They're looking to us to see the strength of our recommendation. Because just like COVID vaccines, patients are really looking that we believe this is a trusted vaccine and this is something that they should do. What are the keys to us improving HPV vaccine coverage in Canada? Number one, we need to increase our school-based vaccine uptake rates. That means we need to increase parental consent. We need coverage for special populations, such as those living with HIV, the immunocompromised, such as transplant patients, those on steroids, biologics. We need to really aim for funded vaccines like Alberta, BC, parts of BC, Yukon, and Northwest Territories, where they're funding certain people up to the age of 26. For example, a lot of jurisdictions are thinking about once eligible, you're always eligible, even if you have left high school. We need to provide education to both patients and providers that gender-neutral adult immunization is of value. So when we look back at our original question, are we on track for 2030 elimination targets? I think the answer is no, and we really all must do more. Thank you so much.
Thank you very much, Dr. Stebbin and Dr. Durand, for these very informational presentations. That was excellent. If our audience has any questions, you can continue to send them in while we start the Q&A period. I see we already have some that have come in, so we will move on right away. So the first question that we've received, what is the main message? If you had to pinpoint, you only have a few seconds, you have one thing you can say, what would be the main message to give patients when it comes to HPV prevention?
The main message, I think, the easiest and quickest, is that this is a vaccine that prevents cancer. We're screening you for cervical cancer if you're a person with a cervix, and that links perfectly with a discussion about prevention. And honestly, we talk for a whole hour about this. My actual conversation with the patient takes me about 15 to 20 seconds max. The shorter the message, often the more effective the message.
Thank you. Yeah, I think that's very important. The short is key. The WHO 2030 goals that we've been discussing today for the elimination of cervical cancer. If these goals are reached, we're talking about the elimination of cervical cancer within a century. But could we also be saying that we will eliminate other HPV cancers, or even HPV itself, perhaps?
Yeah, I think so, that we will have eliminated many diseases, especially if we go with the 9-valent vaccine. You look at the problem it causes, all the low-grade disease that we find when you use cytology. Fair proportion is caused by low-risk HPV. When you look at the risk of acquisition of HIV is stronger in person who clear a low-risk HPV compared to a high-risk HPV. All the lesions in the babies, the respiratory papillomatosis, and we know that 9 different cancers in both male and female are related to HPV, and except cervical cancer that is caused by with HPV 16 and 18 causing 70% of cervical cancer. We know that 16 and 18 will cause 90% and more of the other HPV related cancer. It's very difficult to have something as powerful as vaccine, and and also covered for those HPV that are not in the vaccine, covered by doing HPV testing. We have a very good potential to eliminate not only cervical cancer, but also the other HPV-related cancers.
Yeah, I'd like to mention we didn't have time in this discussion to talk about oropharyngeal cancer of head and neck, which especially is affecting males, 4 to 5 times higher in males. And we believe we're already seeing reduction of oral HPV prevalence in those who have been vaccinated. We've seen that in the USA, we've seen it in the UK in those younger cohorts. So we believe it will also lead to reduction and probably elimination if we have vaccines in people for oropharyngeal cancer. So I think that's important. And I think to Mark's point, as we hopefully move to HPV testing for those with a cervix, again, that will be a very natural discussion, whether you're HPV positive or HPV negative on your result. It's the opportunity as a provider to discuss that we have methods of prevention. If you're HPV negative, this is a great time for you to get HPV vaccinated. If you're HPV positive, this is a great time for you to be vaccinated for HPV. So it doesn't matter what the answer is, it's an opening for us to discuss.
Thank you. When it comes to some of the more vulnerable populations, like new arrivals, some would be interested in getting the HPV vaccine, but it's not possible for everyone to know or have a track record of if they received it back home or not. So people are wondering here, is there a risk of getting the series twice? If ever people are unsure, could we just give it for good measure?
So I'll take that one, Mark. No, there is no risk if you happen to get extra doses. So that's not a problem. The registry idea is a huge issue. As Mark alluded to, we just don't have registries across the country, A, for vaccination, and B, for cervical screening that are adequate. And if you move around, that also becomes problematic. So registries both for vaccination are important, and surveillance methods for screening are very important as well. Those are areas we need to work on in Canada.
Thank you. Is it possible to give, I see a few people that are asking about age. I know it was mentioned that it's recommended for everyone universally, regardless of age. Some people are wondering for the vaccine for over 45 years old, is this being done? And I guess, what have we seen so far?
So I can start, and Mark, you can comment. NACI has no upper age limit. They haven't for many, many years. So we have been actively vaccinating those over the age of 45 for many years. I remember we used to have a vaccine clinic when I worked down at Women's College Hospital, and we would have males coming there to be vaccinated because they couldn't get it elsewhere, including those over the age of 45. So Mark, your comment.
Yeah, and I see a lot of people being referred from the bone marrow transplant unit. And I'm surprised to see sometimes our patients are covered with genital warts. And, you know, it's not a question of age, it's a question of your health, and your risk factors. So especially when I see people coming from outside the country, we saw this huge influx of refugees, and a lot of them come from countries where there's no screening, and also there's a lot of HIV, and there's a lot of sexual violence, and you know, you better give a vaccine too much than a vaccine that will never be given to a person that is a high risk. They come and they don't even know what is HPV, and they say, Quebec women do these things? Say, yes, they do. I'll do it. I come to Quebec. Want to live like the Quebecers. They get the vaccine, they get screened. They don't know, they don't ask. But once you offer, they're very willing when you give them the good information.
I always come back to that question. If you have someone who is not sure about it, if I was talking about a vaccine to prevent breast cancer, or if it's a male, a vaccine to prevent prostate cancer, would you want that? And they realize that the answer is always yes. And I say, we shouldn't look at this differently than that type of a vaccine. We need to understand our own biases, either within ourselves as a patient or within ourselves as a provider, where we don't bring up this discussion because we don't feel we should.
Thank you. I think that's a great point. I'm going to take one more question. Just, I know I'm going over slightly, but we had to shorten the question period. I see a few people have mentioned this, and this is something that comes up in almost every webinar we do. When it comes to committed long-term relationships, a lot of people think that it is not necessary for them to get it because they are with the same person for such a long time. So what is something you can say to explain to people why it's still important, especially considering that a lot of people are not open to hearing the fact that you can never know if someone is truly committed?
I find people are more open than you think they are to this discussion. So a lot of it is our bias about initiating the discussion. However, yes, we don't ever know when our relationship status will change going forward. So not just that people are unfaithful within the relationship, that your relationship may change in the future. One of them may leave without you know it, like that just might happen. One of them may die. The chance that you're going to have a new lifetime partner is extremely high as we get older, more than in the past. We prefer to protect now and not wait for that to happen. We also think about latent infection, where we had infection several years ago and it becomes sequestered, latent, or hidden. We don't know if vaccination may help continue that suppression by boosting our antibody levels, but it is possible that that may be true. This is sometimes how we explain why is someone coming in with new HPV diagnosis several years after they've had a new partner. It can be because of this immune deregulation where it's no longer suppressing it and now is coming forward. Mark, if you want to comment too.
And sometimes the question has to be a little more explicit. So no new partner, whatever sexual activity, and then they change color. And well, I didn't know that with the condom, it should be considered, or oral sex only should be considered. And people forget that they may have acquired HPV before they became in a stable relationship, and that's the HPV we're more afraid of. It's not the newly acquired as much as the old acquired. It's the persistent infection and not the new infection that gives you risk for HPV-related cancers.
Thank you very much. Unfortunately, this is all the time that we have for questions. I know there are still several questions that were left unanswered. However, we will do our best to answer them in written format following this webinar in a timely manner as much as I can. And we will put the answers on the HPV Global Action website so that people can go look at them in the same time as the webinar and the slides. I would like to thank Dr. Stebbin and Dr. Durand for their excellent presentations and for taking the time to respond to the questions from our audience. It's been a pleasure working with you both on this educational webinar. We very much appreciate, once again, the support of Merck Canada for allowing us to bring this webinar to everyone at no cost. Please remember to complete the evaluation survey. You will receive it shortly in a follow-up email with the link. Note that this webinar, once again, has been recorded, and the video, as well as the slides and the questions, will be available on both CIDC's and HPV Global Action website in the near future. There are also several other resources on both websites that I invite you to take the time to look at. We thank you for your interest in our webinars. Please watch for an email notice regarding upcoming programs. Please enjoy the rest of your day.
Bye.
Thank you.